Okay. So I'd like to take this opportunity to talk about some of the work that we have done in the past year. I'm in a lab that works with sepsis predominantly, but when the pandemic hit last year, our focus changed because we are the only lab in the emergency department, and the emergency department being the first stop for most patients who are severely afflicted, we figured that we should get into this research to try and understand what is going on. And please stop me if you have any questions, and I'm happy to take a pause and explain anything better if I have not come across clearly. So for my talk today, I'm going to go over a few basic topics. One is just the state of affairs and the challenges with dealing with COVID-19. Two, I'm going to introduce a next-gen instrument that offers many advantages over typical qPCR machines and allows us to study COVID-19 better. Then I'll delve into our actual study design itself, which is what we did for the past year. And I'll share some of our performance characteristics for the test that we performed and how all of these tie into predicting clinical outcomes for SARS-CoV-2 or COVID-19. So as of the beginning of this week, the pandemic has hit a large enough number where it's globally affected. And as you can see here, just considering the entire planet, we have crossed about 115 million cases, and almost 3 million people have succumbed to this disease. And just in the US and in India, the numbers are staggeringly large, although in India, the death rate is not as high as it is in the United States itself. Nonetheless, this is a serious pandemic that's taken its toll on the livelihood of a lot of people, not just health-wise, but economically and financially as well. So what causes COVID-19, basically? So a little bit of background. COVID-19 is caused by the SARS-CoV-2 virus, which is a positive strand RNA virus. It interacts with the ACE2 receptor in the host, and based on how these ACE2 receptors are being processed, it can affect the viral load being shed from the system itself and leading to a not so severe symptoms and more severe symptoms. So if the viral load is shed out really easily, then the symptoms are not as bad. But if the viral load is not, or if the viral load keeps accumulating in the body, then we are going to see more severe symptoms. So based on the WHO or the World Health Organization, there are some symptoms that we are supposed to look out for. And the most common symptoms are fever, cough, tiredness, and loss of smell and taste. So these one or two or a combination of these are the symptoms that are most commonly afflicting a lot of the patients that we see. Some less common symptoms are sore throat, headaches, aches and pains, some gastrointestinal conditions, and irritated eyes. These are less common, but the most serious direct symptoms from COVID-19 are shortness of breath and difficulty of breathing, loss of mobility or confusion, and severe chest pain. If you come across a patient who has got any of these things, that person's more likely to be admitted to the ICU or at the very minimum need some supplemental oxygen at least. They're not able to breathe room air concentrations. So what is the current testing method? So in a pandemic of this magnitude, the most important thing to control it is effective testing. And the current testing method involves collection of samples either from the nasal passages or from the nasopharynx itself using a cotton swab. And then the RNA for the virus is extracted. From the extracted RNA, then reverse transcription is done, which is basically just reconstructing cDNA. And then you do an amplification to look for specific gene markers. In most cases, it's looking at two separate regions on the N gene and using the RP gene in human beings as a control for the reaction itself. So this is typically done in a qPCR platform, which is quantitative PCR. One big advantage is that it is a real-time PCR reaction, and for RNA samples, it does the reverse transcription as well. But the advantage is that as and when the reaction is occurring, you're able to visualize the results to see if the patient sample is either positive or negative. And this is based on dyes that are released when the reaction occurs itself. So based on the targets that we are probing for, there'll be different dyes. And if you see that a particular dye is being expressed or is being released, then you know that that particular target is found in the sample. If you don't see those dyes being released, then it's a negative sample and you're free and you don't have COVID-19. But there are certain challenges to using qPCR as a way to determine positivity of infection itself. qPCR is a technique that's been used for many years now, and for COVID-19 specifically, a lot of work has been done that shows that qPCR can result in false negative or inconclusive test results. Both of these are big issues when you're trying to determine accurately how many people are infected, because a false negative person or a person who's falsely detected to be negative for SARS-CoV is going out back into the community and then can spread the virus rather easily, because then they're not taking as many precautions since they were tested negative. As for inconclusive test results, this happens when the control for the PCR reaction works just fine, but on the two targets that are being probed, one of them is positive and the other one is negative. So when you get a result like that, you cannot really confidently say that it is a positive or a negative result. So those would be inconclusive test results. And these have had major impacts. And here are just titles from a couple of articles in respected journals that came out last year that talk about the false negative tests and what the implications of these are, and the variations in rates of false negatives based on the qPCR platform or the assay itself that the lab is utilizing to do this test. Another major limitation of using qPCR is that in order to determine the viral load in your sample, you need to have a standard curve. And it is of utmost importance to determine the viral load in the sample. There would be the number of viral particles in the sample itself, because this then gives an idea of how the disease is progressing, if the person is infectious or can transmit the disease rather easily, and how the host or the person is responding to, say, treatments or just their immunological response mechanisms. And the cycle threshold for qPCRs can be pretty unreliable. So like I said, you need a standard curve in order to be able to determine the viral load. So in order to determine a standard curve, you take a DNA standard, perform a serial dilution, and then run qPCR on each of these dilutions to get these characteristic qPCR curves. So basically here, what it is showing us is that this red line here is the threshold for when we would say that that particular dye is showing up as a result. And the CT1, 2, 3 are the cycle threshold values for each of these standard dilution samples themselves. So in short, if you have a low CT number, then that means that there is a larger number of viral particles in the sample. And if it's a higher CT number that comes later on in the curve, then it's most likely that you have negligible viral particles, or it could just be a false number itself. So in order to determine the viral load accurately, you have to go through this entire process of doing the serial dilutions with DNA standards, running qPCRs on each of these, and plotting this standard curve for cycle threshold number against the DNA amount. So if we had the kind of time to do all of these experiments before we need to determine the viral load, and we have a standard curve setup, then all we'd have to do is when we get a patient sample, run the qPCR on the patient sample itself, and look for where along the standard curve it falls in order to determine the number of viral particles. But this is easier said than done. Most labs do not even run standard curves for COVID-19 at least, simply because of the sheer number of samples each lab is having to handle. And all they're really interested in is looking for whether a person is positive or negative, so that treatment can be performed accordingly. So this is not a number that's routinely reported, so you cannot really rely on that. A third challenge with COVID-19 itself is that there are a multitude of symptoms and manifestations. So going back to the WHO chart for the COVID-19 symptoms, there are some of the most common symptoms, as I discussed before, some less common symptoms, and some rarer or common symptoms that require immediate medical care. But for this one virus, there is already a variety of symptoms that this one virus can cause. But apart from these simple symptoms, this virus can also cause a bunch of different extrapulmonary manifestations. So these are conditions that are outside of the pulmonary system itself, and it is spread throughout the body. So you can have neurological symptoms where you have forgetfulness and headaches and dizziness, renal symptoms leading to acute kidney injury, thromboembolism, where the neutrophils in the immune response are hyperactive and cause the formation of blood clots in different parts of the body. There could be cardiac issues, hepatic issues with the liver, endocrine, gastrointestinal, and dermatological. So we don't really know yet how this virus that is typically entering through the nasal passages is causing all of these different manifestations. So last year, some work came out where the SARS-CoV-2 RNA was found in blood of patients. And this is just one study that showed that. So it's also been found in stool, in tissues, in histopathological studies. Coroners have found blood clots in distant systems in patients who have passed away because of the condition. So we wondered towards mid to late last year if this viral RNA in the blood could be the reason why this effect of this virus is seen in multiple different systems all over the body. So the question was whether we could use this viral RNA in the blood to see if that directly correlates to different extrapulmonary manifestations or even just severity of the disease itself. So I've talked about the major limitations of qPCR, and I've And I've set up the initial question that we wanted to answer. So we wanted to take advantage of a newer technology that had advantages over regular qPCR in dealing with minute quantities of patient samples coming from blood or all these complex sample types themselves. So one of the big advantages of digital PCR is that it can give an absolute quantification of nucleic acid targets without the need for standard curves themselves. So I'll explain that a little bit more. And it also uses a partitioning of bulk sample into smaller individual reactions. So if you have, say in blood itself, if you're looking for small numbers of viral particles or viral RNA amongst many blood cells or host RNA itself, partitioning the sample into thousands of smaller individual reactions would help in determining these small numbers of viral RNA particles amongst these complex sample types themselves. Some other advantages are that digital PCR offers really high sensitivity. It gives us absolute quantification, so it can tell us the number of copies of viral RNA per microliter of sample. And since these reactions are going on in really minute volumes, we are tolerant to a lot of PCR inhibitors also. A really good example to discuss how digital PCR works itself would be to try and identify where Waldo is in this picture. So if we took this picture and we had to identify where Waldo, the person in this postcard, is, it's going to be a nightmare because he is one among 1,000 people on here. But what digital PCR offers is that it breaks all of these into individual tiny cells. So now instead of looking at this entire picture, you can look at each individual cell to look for whether Waldo is present there. And since it is a qPCR, an evolved qPCR method, you then use probes and primers specific to the target you want. So say here you want to look for Waldo. Here you're looking for Waldo. You find something that's specific to Waldo and use that as a probe or a primer, and that'll give you the exact spot where Waldo is. So this is a simplistic, figurative way of how digital PCR works itself. So it gives us this big advantage where a bulk sample can be broken down into thousands of tiny samples, and it helps us look for our small sample type amongst these individual minuscule samples themselves. So what we chose to do was use a microfluidic array-based digital PCR. So there are two major mechanisms for digital PCR currently in the market. One is a droplet-based mechanism, and the other is a microfluidic array-based mechanism. So in a droplet-based digital PCR, what is happening is your sample reaction or the reaction mixture is getting enclosed in a droplet, and that then gets pushed into different wells. But in a microfluidic array-based digital PCR, in a microfluidic array-based digital PCR, on the left here is a zoomed-in version of what this array looks like itself. So each of these tiny wells, as the sample is getting pushed through these capillaries, will get filled up with picoliter volumes of your sample, and then these are physically separated from one another, and then reactions happen in 1, 2 in each of these little wells themselves. There are advantages to using array-based digital PCR over droplet-based digital PCRs, and some of those are listed here. So one, it's it's shown to be more consistent and precise than a droplet-based digital PCR, simply because these droplets that are being formed are easily affected by changes in chemical balances and whatnot. Also, the array-based digital PCR maximizes the use of input volume. So with digital PCR platforms, there is this concept of a dead volume. So this is a proportion of your sample volume that does not get utilized at all. So with droplet-based digital PCR instruments that are in the market currently, this dead volume can go anywhere from 35 to 70%, which means that in some instruments, up to 70% of your initial sample is not even used. And when you're working with patient samples, you get really, really small quantities to begin with. If you're not using 70% of this initial sample, then you're missing out on a lot of information anyway. But with array-based digital PCR, it has been shown that 95% of the sample is used. So only a 5% dead volume is present with this mechanism. So that's a drastic advantage over the droplet-based methodology itself. So keeping all of these in mind, we had a few study objectives. So we wanted to use an array-based digital PCR method to evaluate the test characteristics of a particular PCR assay for SARS-CoV-2 RNA. So this particular triplex digital PCR assay is an assay from one particular company that has its own combination of primers and probes and polymerases and the enzymes and everything. And there are multiples of these out in the market at this point. But we wanted to start off by evaluating the test characteristics of this particular assay first. If we were able to see that the digital PCR platform was working well with detecting SARS-CoV-2 RNA, we then wanted to look for whether SARS-CoV-2 RNA has a relationship with overall disease severity, clinical deterioration, and extrapulmonary complications. So I've talked about how most of the testing is done from either the nasal swabs or nasopharyngeal swabs, and some previous work has shown that RNA is found in blood. So what we wanted to do is try and extract SARS-CoV-2 RNA from plasma and then do all of these things. There are a couple of limitations to our study. One of the limitations is that it cannot be generalized because our study revolves around only a single center. So all of the patient samples we collected are only from patients visiting the Stanford Emergency Department. So we don't know how generalizable some of these findings are if you would compare it with patients coming into other hospitals or other centers themselves. The methodology is definitely applicable, and some of the findings are applicable, but overall generalizability, we can only tell if this can be expanded to other centers as well. And there's one major caveat to studying RNAemia, which is the viral RNA in blood. So we are only measuring viral RNA in blood or plasma. Based on finding viral RNA, we cannot actually say if these are circulating infectious viral particles. So we have ongoing work where we are trying to culture viral particles from patient samples to see if they are viable. But in our study that I'm going to talk about and that I've been discussing so far, we are only looking at whether viral RNA is present in the samples themselves. So the study design was when patients would come to the emergency department at the Stanford Hospital, we would test to see if they were positive or negative. And if they were positive, we would collect samples, biospecimens. As a part of our Stanford COVID-19 biobank itself, we have collected nasopharyngeal swabs, blood for plasma, blood to study the host RNA itself. We have collected other cell types like the immune cells and whatnot. But for my talk or my portion of this work, we are only looking at blood that we collected specifically for plasma. So we collected day 0, which is when patients are enrolled. And for some patients, we collected samples from days 3, 7, and 30 since time of enrollment. For all of these patients that we enrolled, we also collected phenotypic data. So by phenotypic data, I mean all of their lab results, the oxygen saturation numbers, blood pressure, if they've had symptoms and what kind of symptoms, how long the symptoms have lasted, and so on and so forth. And using information from the phenotypic collection, as well as the data from the biospecimens themselves, we then do a systems level biological research. So the basic assay workflow is when we collect blood, we collect them in tubes with EDTA, which is a chelating agent. From these EDTA tubes, we then extract plasma, and then from the extracted plasma, we use an automated instrument to extract RNA, viral RNA. So the QIAcube, at least the instrument we have, can automatically extract RNA in about 12 samples at a time. And the entire RNA extraction process takes about 90 minutes. So in one day, we can process many batches of these 12 samples. Once we have extracted RNA, we set up the PCR reaction and load the reaction into these plates. So this particular plate is specific for the digital PCR instrument that we use. And the samples that go into these plates are then partitioned into these individual wells. So on these plates, I hope all of you can see these purple caps on there. On each of these plates, we can load up to 16 samples. And when we load 9 microliters of our sample into one of these wells, what happens is that the 9 microliters gets evenly distributed across 20,000 partitions. So for each of these little circles that we load sample into, the sample is distributed into 20,000 of these. So we do 20,000 partitions, or the input is divided into 20,000 partitions so that we can look for the viral RNA even in the tiniest of input sample itself. So once this plate is ready, we load it into this PCR instrument. It's very straightforward. All we have to do is load this plate, put it into the instrument, and run it on the computer. That again takes another 90 minutes, and we have our data. So this is the overall workflow of our assay. So what happens is in the assay that we set up, at least it's a multiplexed assay. So in each individual reaction, we can look for multiple targets. And what we have identified is that when we did serial dilutions, we identified that the instrument can detect as low as 200 copies of the viral RNA in 1 milliliter of the sample. And we are only working with microliters of samples, so we can detect enough copies of the viral RNA if it is present in there. So when we started off, we had to do some limited detection studies. And as I mentioned, each of these were partitioned into 20,000 little wells. So for limited detection, we were looking to see if at least 2 of these little wells were positive for our samples. And when we did the assay, we were looking for 2 regions on the N gene of the viral RNA itself. So we did a serial dilution going from 1,600 copies per mil all the way down to 50 copies per milliliter. And we only considered the sample to be positive if both N1 and N2, the two N targets were positive indeed. So the limit of detection I'm showing you right now is for nasopharyngeal swab samples. Since the nasopharyngeal swabs are the most commonly used ones, so we wanted to make sure that our assay worked well on the most commonly used sample type itself. We did 9 replicates of each of these, and as you'll notice, going down to 200 copies per milliliter, we were able to detect positives in at least 2 wells in 9 out of 9 samples. Even down to 50 copies per milliliter, we were able to detect it in 2 and 4 wells respectively, but we wanted to be very conservative in our identifying and estimating the number of copies per milliliter of the viral RNA. So we set 200 copies as our cutoff. We didn't want to take a chance with anything lower. We also then did limited detection with plasma itself. Here we did concentrations of 800 copies per mil all the way to 0. And again, we tested for N1 and N2, and we only did 2 replicates because these were contrary blood samples where we spiked inactivated RNA to do this kind of analysis. And again, down to 200 copies per milliliter, we were able to detect it in 100% of our replicates, which is good. So we knew that our assay was working just fine. Next, we wanted to see how dPCR or the digital PCR stood up against qPCR itself. So for this, what we did was we took 80 patients, which were a combination of positive and negative patient samples themselves, and we ran qPCR and dPCR on each of them to see if digital PCR offers a better sensitivity in our study as well. So in this table here, the columns represent the findings from qPCR, and the rows represent the findings from the digital PCR. So with qPCR, we found 48 positive NP samples, 18 were negative, and 14 were inconclusive. So with inconclusive, it just means that either N1 or N2 was positive and the other marker was negative. So we couldn't confidently say that it was positive or negative. But when we looked at digital PCR identified 65 to be positive and 15 to be negative. Excuse me. So with this 65, if you look at the breakdown, digital PCR identified all 48 that were positive by qPCR, and it also detected 4 to be positive that were initially determined to be negative by qPCR. So these were false negatives by qPCR. Apart from that, out of the 14 samples that were inconclusive, digital PCR was able to resolve 13 as positive and 1 was negative. So overall, digital PCR did not leave any inconclusive results at all, and it was able to identify even ones that were false negatives using qPCR itself. So it resolved all of the inconclusive tests. So that is good. So we've tested our assay and also checked for whether the dPCR was giving us an advantage over qPCR. Apart from just the theoretical advantages, we were also seeing that in actual patient samples, it is giving us a better advantage than qPCR. So next, we started focusing on the viral RNA in plasma itself. So what we found was when we tested 119 patients, only 44 were positive for RNA, viral RNA in plasma. So that comes out to about 24% of patients who were RNAemic or had viral RNA in their blood. We also noticed that digital PCR detected 16 times more patients with RNAemia than qPCR did. But most interestingly, though, the correlation between the viral load for nasopharyngeal swabs and plasma was pretty weak. So this got us wondering as to whether there was a direct connection between the viral load in the nasopharyngeal area and the blood. So it looks like what we are finding in the blood is not just a wash through from the nasopharynx itself. So it's not that just because somebody is COVID positive and have a high viral load in the nasopharynx, that the viral particles can actually make it into the blood itself. So there could be other driving factors that are leading to viral RNA in the blood. And since we were interested in correlating viral RNA to the severity of the patients themselves, we defined a severity score based on the WHO severity score itself. So here, we modified the WHO severity score based on the oxygen requirements for patients in our hospital. And we classified the patients as 1 through 8, where 1 and 2 were mild, and they were either asymptomatic and did not require admission, or symptomatic and did not require admission. So these are patients that did come in, might be symptomatic, but they were doing fine with their oxygen requirements, and so in an effort to save hospital resources, they were discharged. We defined moderate as patients who were admitted with only minimal supplemental oxygen or no supplemental oxygen at all. And then all patients who required high flow supplemental oxygen or mechanical ventilation, or patients who passed away from the disease, were classified as severe. So out of the 191 patients that we had in our study, a majority of them were moderate, followed by mild, and only a handful, over 20 or so patients, were actually severe in the disease itself. So we did digital PCR on the plasma samples, estimated the amount of viral RNA in them, and then we did some analyses on how they correlated with severity itself. So what we found was that RNAemic patients had a higher mean 30-day severity. So if you remember back, we were collecting samples up until 30 days post-enrollment. So what this means is that anybody who was positive for viral RNA had a higher severity within the 30-day period than those who did not have viral RNA in their plasma. Also, 41% of RNAemic patients eventually developed severe disease as compared to patients who are non-RNAemic. So these are big differences. So this is telling us that viral RNA in plasma is directly related to severity. And only 4% of patients who were initially RNAemic at day 0 had mild disease, compared to 35% who are non-RNAemic. So here the numbers go other way. If you are negative for viral RNA in plasma, then you have a better chance of having a mild disease than patients who had viral RNA in plasma itself. We did some correlations based on the viral load. So viral load is the number of copies of viral RNA in the plasma itself. So what we found out is that patients with higher initial viral load did manifest more severe disease. So you would notice that in the plot on the right here as well. And severity did trend higher in persistently RNAemic patients. So persistently RNAemic patients are those that had viral RNA in plasma for multiple days. So as we collected samples from days 0 to 30, all patients, or most patients that had viral RNA in subsequent follow-up collections, tended to be more severe in their disease itself, as compared to patients who had viral RNA in plasma on day 0, but eventually cleared it. We also saw that viral RNA in plasma can be correlated with clinical deterioration itself. So 36% of patients who were initially RNAemic and 19% of the patients who were non-RNAemic had clinical deterioration. So if you had initial viral RNA in your plasma to begin with, then you ended up worsening in your disease over time. So that's what that means. And the number by which you get worse is a median of 3 points. So on a modified WHO score, a 3-point difference goes from mild to severe. And that's what's happening with 36.4% of initially RNAemic patients. So all of this is showing us that viral RNA in plasma itself has quite a bit of a detrimental effect on just prognosis of patients with COVID-19. We looked for the dynamics of infection, if you will. So we followed 27 patients through time, and we looked for how their infection or the severity changed through time, and correspondingly how their viral RNA changed through time as well. So on the plot here, each row represents a particular patient. So we have going from 1 through 27. The lines represent change in the WHO score, and the box right below that represents the number of copies of viral RNA in the plasma. So if it's a box that does not have a cross in it, the patient did have viral RNA in plasma when that sample was collected, but in the subsequent sample, there was no viral RNA detected. So viral RNA was cleared from the system itself. So what we notice is that it's pretty mixed, right? So some patients have really high viral RNA, but maintain pretty high viral RNA through time. Some patients clear viral RNA relatively immediately, but there are a couple of examples where the viral RNA in plasma actually increases. So in this one example here, it started off pretty low, but as the subsequent samples were collected, viral RNA in plasma kept going up. So based on the kinetics, what we determined is represented on the right here. So the first plot on the right here is a representation of the copies per microliter of the viral RNA with respect to the days after onset of symptoms. So what this curve here is showing us is that the peak in viral RNA is at about 3 days post-symptoms. So if somebody starts having symptoms and is positive for viral RNA in plasma, the peak concentration is at around 3 days post onset of symptoms. So viral RNA, it peaks at 3 days, but the severity itself only peaks at 14 days. So what that is telling us is that even though the viral RNA could be cleared in plasma, for patients who have viral RNA in their plasma, their severity still tends to increase later on. So even though the peak for viral RNA is at 3 days, severity still continues to increase and peaks at 14 days. So there is a disconnect between when the viral RNA is at the peak and when the severity is at the peak. But this is also how typical viral kinetics themselves are for infectious diseases. And for the last part, we looked for how viral RNAemia compared to extrapulmonary complications. And we looked at these extrapulmonary complications listed below. So neuro, renal, hematological, and immune systems, hepatobiliary as well. So what we saw that based on whether a person was positive for viral RNA or not in plasma, it was significant for hepatobiliary extrapulmonary complications, hematological complications, and immune system complications overall. So in each of these, the difference in the proportion of RNAemic to non-RNAemic patients who had these extrapulmonary complications is statistically significant. So patients who were RNAemic tended to have more hepatobiliary and hematological and immune complications as compared to non-RNAemic patients. So these are all based on observed patterns. So next we wanted to do some mathematical modeling using linear regression and predictions to see if when a patient comes to the emergency department and we are able to detect RNAemia in the patient, can we use that as a predictor of severe disease? And that is exactly what we can see here. So we see that RNAemic patients had a high log odds ratio of predicting severity itself. So this is a pretty good number and falls within the 95% confidence interval. And what is important is that it is similar to, or even better than, low saturated oxygen levels. So we know that if a patient had low oxygen saturations and they are tending to severity, and our prediction also showed that patients who are RNAemic were also predicting severe diseases later on. So that was one of the prediction models that we generated. Secondly, we also saw that patients who are RNAemic or RNAemia itself can be an independent predictor of extrapulmonary complications themselves. So here, we weren't separating individual extrapulmonary complications. We were just looking to see if a patient had any extrapulmonary complication or not. And we used all of these different clinical parameters and RNAemia to see which of these can be independent predictors of extrapulmonary complications. And in fact, RNAemia was an independent predictor of extrapulmonary complication. On the flip side, though, we wanted to see if when a patient comes in, we are able to take their symptoms and whether we can predict whether the patient is RNAemic or not. And that turns out that that is not really the case. So clinical parameters like the symptoms and the low oxygen saturation are not really strong predictors of RNAemia itself. So there is no correlation between a patient having these symptoms and being RNAemic. So to end my talk, a brief summary and conclusions from all that I've showed you. Digital PCR, in fact, does have superior sensitivity and reliability over qPCR in both NP or nasopharyngeal samples as well as plasma. We also show that RNAemia is a strong independent predictor for severity, clinical deterioration, and extrapulmonary complications in COVID-19 patients. And we suggest, or we put forth, that testing for RNAemia should be done early. So when a patient comes in, we should immediately test for RNAemia in their blood so that we can predict whether this patient is going to worsen in their clinical symptoms and whether more aggressive treatments are needed so that they can survive or have a better outcome. So a lot of people are involved in this work because the biobank that these samples go into is a huge undertaking itself. So I'm a postdoc in the Yang lab, and we are the only lab in the emergency medicine department itself. Some of the others who contributed to this work are David, Elizabeth, Marjan, and Crystal. We have a bunch of collaborators who are a part of the biobank as well. Combinati is the company that provided us with the digital PCR instrument. We received funding from NIH for this work. And with that, I'd like to thank all of you again for inviting me to give you a little talk about the work that I've been doing and for patiently listening to all that I've had to share so far. Please feel free to ask me any questions you might have. Thank you.
Thank you so much, sir. And now it's the time for the discussion. So participants, please do feel free to type your questions in the chat box. And let's start our discussion session. So let's start with the major concern. So here's a question from Mr. Safir. He's asking that how long it will take to eliminate this pandemic completely.
So that's a tough question, right? So with the development of these vaccines, we are getting a little closer, but it is still going to take a while before everybody can be vaccinated. So I think the current prediction is that it's going to be at least until the end of this year before everybody in the United States can be vaccinated and life can go back to some kind of a resemblance of normalcy. So I believe if we can continue vaccinating at the same rate and there are no development of new variants or strains that are resistant to the vaccines, I believe we might come back to a sense of normalcy sometime next year. But I only have a little bit of experience with this, so that's just my opinion.
Thank you, sir. Thank you so much.
Sure.
And here's the next question. That is it possible to use viral RNA binders to restrict the replication of virus in infected cells? It's asking, shall we use viral RNA binders for treating COVID-19?
I guess it's possible. I think the challenge there is, for one, it has to compete against the virus binding to the ACE2 receptor itself, which has been very, very efficient so far. I believe most of the variants that are out there now can very efficiently bind to the ACE2 receptor. So coming up with a way to inhibit that by binding the viral particles to another molecule would have to compete efficiently against ACE2 binding itself. Maybe that's work going on in other labs, but that's not something I have come across myself.
Okay. Thank you, sir. Again, a question from the same stream, I think, from Mr. Nampi Rajan. He's asking, isn't interferons are restricting the viral replication, so it won't stop the replication of COVID-19?
I'm sorry.
So shall we use interferons as a treatment or another option?
I guess so. But again, there are these challenges with using interferons as well, right? For all of these, you're considering actually injecting patients with these treatments. So we have to think about how these might affect normal functioning as well. So there are these drugs like remdesivir, and there's one other drug that I cannot recall off the top of my head right now, which are being administered to more severe patients, but these are only saved for patients who are extremely severe. But using remdesivir and some of these other treatments, those directly affect the viral particles themselves without having a direct major effect on the host. So maybe that could be a challenge with using interferons. But I'm just hypothesizing here.
Okay. Thank you, sir. And next question is, which PCR is more accurate for COVID-19 testing?
So I would say digital PCR, but it's not as widely used right now because qPCRs are more widely available. And not all digital PCR instruments can be easily incorporated. So the instrument that we use that can take the same reaction mixture that you would have for a qPCR and run that. But for a lot of the other instruments, that is not as easily doable because there is an initial step of making these droplets as well. So it then becomes a multiple step process that's not very conducive for testing purposes itself. So if you want to do array-based methodologies, that might be easier, but they're not as widespread. They're not as easily available at this point. So I think qPCR would still be the best option.
Okay. Thank you, sir. And next is why it shows negative result in antigen testing and positive in RT-PCR.
So for one, so there is no guarantee that the sample itself has gotten into the blood, right? And with RT-PCR, you're just looking for RNA itself. So irrespective of whether the viral particles are actively replicating or not, or if there's an immune response or not, we can just look for the RNA particle to see if this person is infected, or that's it. You cannot say this person is actively transmitting or if the infection is current. It could just be a past infection that they have, but that person was still infected with COVID-19. So that could be a big reason why there is a discrepancy like that.
Okay. Thank you so much, sir. And next question is from Ijaz Ishtiaq. He's asking that can climate change affect COVID-19 virus? If yes, then for the good or the worst?
So that's a great question. I honestly don't know. So from my experience here, at least, there was a little bit of hope that when the weather got colder here, transmission might reduce. But in fact, what happened was the exact opposite, because the rate of transmission and the infectivity went up during December and January, right? So it's the exact opposite. So I cannot give you a conclusive answer there. But from what I have experienced so far, is that I have not seen really a difference itself, because even in December and January, we cannot really attribute that to the climate. It could just be that more people were traveling for the holidays, which for some reason they were still doing, even though they were asked not to. But yeah, I don't have any evidence to suggest climate change can affect the virus one way or the other.
Okay, sir. Thank you so much. And here's our last question, I think. Is asking, are asymptomatic patients less contagious or pre-symptomatic patients less contagious? Who's less contagious, asymptomatic or pre-symptomatic people?
So we don't know yet. So even in the study that I've shown you so far, we only looked at 191 patients, but our biobank is up to about 650 patients so far. And out of the 650 patients, maybe about 80% or more are all COVID positive, but not everybody is symptomatic. And these are patients who have spread it amongst their family and friends as well. So at this point, at least from our data, we cannot say that we cannot say one way or the other, symptomatic or asymptomatic, because we are seeing evidence for transmission in both cases. I'm sorry, I don't have a better answer for that question.
It's okay, sir. Thank you so much, sir. And one more question is here from Kohila. She's asking, as per recent reviews, some of them said 28 days duration is needed between the first dose and second dose of COVID vaccine, produce 50% of immune response only. So 8 weeks to 12 weeks means, does it increase up to 80%? Which one is correct, sir?
I'm not directly involved in the vaccine work itself, but from what I've read regarding the Moderna vaccine, at least, is that the effectiveness does increase with increase in duration between the two doses. So that was the UK's major justification for using most of their doses to give the first shot rather than saving them to give already vaccinated people their second dose. But that's only evidence from Moderna that I have read. I have not read anything about Pfizer or Johnson & Johnson at this point. But at least at Moderna, for the second dose, if you give it a longer period of time, they have seen better efficacy for sure. Yeah.
Okay, sir. Thank you, sir. So now I think we came to the end of our discussion session.
Okay.
We have received no more queries. So may I now invite Ms. Alfie Nisa Stephen to propose the vote of thanks. Ma'am, please.
Thank you, Tasni. Honorable Speaker Dr. Nigel Ramohan, Postdoctoral Fellow, Stanford University of Medicine, Respected Principal Dr. Sunu Kurian, Respected Manager Dr. Junaid Rahman, our beloved HOD Mrs. Rahimul Gomes, and all the participants here. It is my privilege to have been asked to propose a vote of thanks on this occasion. Let me first of all start by giving glory to Almighty God for making today's occasion a resounding success. First and foremost, I thank our special guest and my dear classmate, Dr. Nigel Ramohan, who despite his busy schedule has found time to grace this occasion. Today's lecture was full of knowledge and interesting things. It gave deep insight into the topic and also revealed many informative facts. Also, I express my heartfelt thanks to Dr. Sini Kurian and Dr. Junaid Rahman, our manager, for their unstinted support for this function. My heartfelt thanks to my dear colleagues for their valuable contributions, guidance, and encouragement in all our efforts. I owe special gratitude to all our participants present here, accepting our invitation. I thank the members of the media for evincing interest covering the event and all good hearts who work behind the screen. Thank you.
Thank you, ma'am. So now we came to the end of the session. So thank you once again. Participants, please do fill the feedback form and the link is provided in the chat box. Then only we can issue the e-certificate for you. So please don't forget to fill the feedback form. Thank you. Thank you once again.
Thank you, everybody.
Participants, please do fill the feedback form provided in the chat box. The link is provided in the chat box. Then only we can issue the e-certificate. Thank you and thank you once again.